difficulty in turning side of set hormones, difficulty in raising from the bed for 1 month. History of stiffness of the right lower limb followed by the stiffness in the other limbs for the past 8 months. And it was associated with hands and the foot present and twitching over the right 2 months. But it was not associated with the nasal twang of voice, no history of nasal regurgitation, breathlessness, or stridor. Solids for the past 1 month. No history of drooling of saliva or spillage of food, no history of unintentional weight loss, no history of recurrent cough or recurrent respiratory tract infections, history of emotional ability present, no history of difficulty in perceiving smell, no history of difficulty in vision or color perception, no history of double vision while seeing with both eyes, no history of drooping of eyelids, no history of difficulty in moving eyeballs in all directions, no history of difficulty in chewing food or dropping of jaw, no history of difficulty in opening or closing the mouth, no history of difficulty in perceiving sensation over the face, no history of deviation of angle of mouth to right or left, no history of drooling of saliva while eating or drinking, no history of hard of hearing, tinnitus or spinning of self or surrounding, no history of nasal regurgitation while drinking, no history of nasal speech, no history of difficulty in controlling the tongue or manipulating food in the mouth, no history of difficulty in negotiating in the narrow pathway, no history of spillage of food around the plate while eating, no history of spilling of water while drinking, no history of speech disturbances, and there was no history of tremors while reaching for the objects. And there was no history suggestive of autonomic nervous system involvement, such as abnormal sweating or chest pain or palpitation, and bowel bladder habits were normal. No history of speech or memory disturbances, or behavioral disturbances, no history of seizures, no history of hallucinations, no history of fever, vomiting, or neck stiffness, no history of headache, no history of cough or a loss of weight or a loss of appetite. Sir, can I continue, sir?
Continue. Summarize. You can summarize now. No, history not yet finished, la?
Yes, sir. Past history. Past history, she was not a known case of diabetes, hypertension, or CAD or CKD. No history of HIV, syphilis, or pulmonary TB, malignancy, or thyroid disorder. No history of any recent surgery or native medicine intake. Family history and personal history was insignificant. Somebody, a 41-year-old female admitted with complaints of chronic progressive neurological illness in the form of asymmetrical onset of spastic weakness of all 4 limbs. Initially in the right lower limb, and then on the right upper limb, followed by the left upper and the lower limb, with the distal weakness more than the proximal weakness, associated with the thinning of limbs, crampy pain in the legs, and twitching. Renal nerve involvement was present in the form of difficulty in swallowing and speech disturbances, with the intact higher mental functions, sensory system, and intact extrapyramidal symptoms and autonomic nervous system. So the likely structures involved was bilateral pyramidal tract and bilateral corticobulbar fibers.
Doctor, are you able to hear me?
Yes, sir, I am able to hear, sir.
You said emotional debility.
Yes,
What
sir.
is it? What she had?
Sir, she was when we say some sad news, she was laughing for that, and when we say something good, she was about to cry.
Unprovoked laughter, crying,
Yes,
anger
sir.
outburst.
Yes, sir.
What emotional instability she had? She is having.
Sir, she was having a anger outburst was present, sir. And when something good was about to tell, she used to cry, sir. She used to cry a lot.
Okay. Any other structure? Any other structure involved? If from your presentation, you said pyramidal tract, corticobulbar fibers. Any other structure involved?
Cerebellar connections.
What is the reason for wasting, thinning, twitching?
Element weakness.
Due to?
Anterior console involvement.
Due to?
Anterior console involvement.
Why you are not mentioned here?
Okay.
Okay. So there is involvement of
Anterior console.
corticobulbar fibers, anterior horn cells are there from the history.
Yes.
Anterior horn cells are there. So lower limb, upper limb, everything is bilaterally affected. Okay. Pure motor. And insidious onset and progressive.
Yes, sir. Gradually progressive.
Yes,
sir. Progressive, sir.
It is progressive course. Okay. So what is it? Where is it? How is it?
So initially it started in the right lower limb, sir. And then it gradually involved the right upper limb, followed by the left upper limb and left lower limb, sir.
So what? Discuss, doctor.
It gradually involved. It is a chronic progressive neurological deficit, sir.
Gradually progressive, little progress rapidly, Within 1 year, she developed all limb weakness, bulbar weakness.
Yes, sir.
Okay.
Yes, sir.
Okay.
And there was no sensory system involvement. No sensory system involvement. Only pure involvement present, sir. Bowel bladder not involved.
Okay.
Extraocular muscles not involved. There was intact sensory system.
Only bulbar muscle involved.
Only bulbar muscles involved,
okay.
Sir.
So what could be the possibilities?
The possibility could be pure motor weakness. Or neuromuscular junction involvement, sir. But since there was no diurnal variation, NMJ is ruled. It could be a motor weakness.
Motor neuron disease.
Sir. Yes, sir.
So you said some twitching, yeah?
Yes, sir.
Is it a benign fasciculation or a pathological fasciculation?
It's a benign fasciculation, sir. Benign fasciculation, sir.
What is benign fasciculation? How will you differentiate from pathological fasciculation? So benign fasciculation present in anxiety individual. It is more common in the localized area, cough, muscle, eyelid, etc. It is not associated with any weakness or wasting. Okay. But here, are you able to hear, doctor?
Yes, sir, I am able to hear, sir.
Here the weakness, there is a wasting and twitching. Is it benign or a pathological fasciculation?
Pathological wasting, pathological twitching, sir.
It is not benign fasciculation. Okay. Which one persists during sleep?
Pathological persists during sleep.
Okay. So it is a pathological fasciculation. So with this clinical presentation, any higher mental function disturbance the patient had?
No, sir, except for the emotional ability, everything was intact, sir. Is
it important in this case to ask the history of cognitive dysfunctions?
Yes, sir.
Why? What cognitive functions?
Motor neuron disease, cognition will be unaffected, sir. And to differentiate bulbar and pseudobulbar palsy,
cognitive function unaffected in M&D. Is it correct?
Later onset can be involved.
Are you heard of spectrum of ALS? Any frontotemporal dementia, frontotemporal lobar degeneration? Are you heard of it?
Yes, sir. In 10% of individuals, Later on frontotemporal dementia and OA6.
See, it is ALS is a spectrum. Okay.
Okay, sir.
ALS is a spectrum. It involves multiple area of the neuroaxis. Cognitive function, one spectrum is frontotemporal dementia. Another side is pure ALS. So you have to ask more about cognitive dysfunction in this case. Whether he is apathetic, disinhibition, okay?
Yes, sir.
Particularly frontal lobe dysfunction. You have to ask. Language dysfunction. All this thing you have to ask in this case. Okay, so very important. ALS asking cognitive function is very, very important. Number one.
Okay, sir.
Okay. Okay. So
Okay,
what
sir.
other past history very important in this case? Exposure to radiation. Exposure to radiation. Delayed radiation can produce similar to electric shock. All this thing you have to ask. In this case. Okay. So where will you localize the lesion here? Spinal cord, brainstem, or cortex?
The spinal cord, sir. Anterior conscience.
So you are localizing one is anterior conscience of the spinal cord. One, as evidenced by twitching, thinning, okay?
Yes,
associated pyramidal symptom. Okay. Then only spinal cord. What is the reason for bulbar weakness, difficulty in swallowing, and emotional instability? You only said cortico-bulbar involvement. I think you keep your. You can speak with the mic, okay? Hello.
Gayatri, your voice is broken.
UAM involvement in medulla.
What's it?
Yes, sir. Sir, can you hear me, sir?
Hear me. Oh, okay. So apart from spinal cord, what other structure affected here? Which one produces emotional instability?
Pseudobulbar palsy, sir.
Okay, pseudobulbar. To produce pseudobulbar lesion must be where?
In the upper motor neurons, sir. It should be in the.
So it must be above the midpons. Okay. The corticobulbar bilaterally must be affected. It must be above the midpons. Okay. Then only produce pseudobulbar. Okay.
Okay, sir.
So the patient has bilateral, number one, bilateral corticospinal tract. Corticospinal, not only spinal cord, but also corticobulbar fibers, anterior console involvement, and insidious onset and progressive.
Okay, sir. Okay, sir.
So a combination of element, lower motor neuron involvement, and upper motor neuron involvement. Okay.
Yes, sir.
So it is progressive course. Yeah.
Yes, sir.
1 year duration. Now tell me what could be the possibilities?
It would be ALS, sir, amyotrophic lateral sclerosis, because there was both UMN and LMN features are present, sir.
Pure motor, no autonomic involvement. You are suspecting ALS, okay?
Yes, sir. Yes, sir.
So ALS, which age group it is more common?
Above 60 years of age, sir. Above 60 years.
So more than 50 years, it is more common. But here it is around the age. What's the age here?
41, sir.
40. So fourth decade.
Yes, sir.
ALS can occur any age nowadays. Okay.
Yes,
but
sir.
More common usually after the age of 50. But it
yes, sir.
started early. Little
Yes, sir.
started early and progress also little fast.
Yes, sir.
Within 1 year, all limbs involved, bulbar region involved.
Yes, sir.
Is it typical
Yes, sir.
ALS, typical ALS, or it deviate from typical ALS?
No, sir. It deviates, sir. Typically, ALS occurs more than 5th or 6th decade only, sir. And there will be a slow progression.
What are the various types of presentation of ALS? Is it spinal onset? Is it bulbar onset?
Bulbar onset ALS, sir.
Hmm?
Sir, one வந்து classical ALS, sir. It is more common and follows the classical symmetrical pattern.
So
And
in this case, is it spinal onset or bulbar onset? Started in the lower limb, then upper limb. Okay.
Yes, sir. Spinal onset, sir.
Lastly, bulbar. Okay, so it is a spinal onset now spreading to involve the bulbar region. Okay.
Okay, sir.
So bulbar, do you think it is LMN or EMN?
Bulbar, I think it is UMN, sir, because emotional ability is also
Very
present.
good, very good. Because of the emotional instability, probably it is a EMN. How will you differentiate LMN bulbar weakness from EMN bulbar weakness?
In LMN bulbar weakness, there will be a flaccid dysarthria. In UMN, there will be a spastic dysarthria. And in LMN,
during examination, history-wise, how will you differentiate whether it is LMN or EMN? One is you said emotional instability.
Yes, sir.
Then second, which condition you will get severe dysphagia, aphonia, all this thing, LMN or EMN?
LMN, sir, because there will be flaccid.
LMN only you will get a severe dysphagia, nasal regurgitation, okay? But comparatively to EMN, it is severe in LMN. EMN, you may also get a dysphagia, but compared to LMN, it is less severe with the spastic speech, okay?
Yes, sir.
So apart from ALS, what other you can think of?
So because the condition seen with both UMN and LMN, it will be one motor neuron disease.
ஒரு மீட்டிங்ல இருக்கேன் அப்புறம்
cervical cord compression, non-compressive myelopathy, or it would be metabolic causes like B12 deficiency.
Now the lesion is above the bulbar, okay? It is got the brainstem. Why you are going for cervical myelopathy and all these things? Okay?
Yes, sir.
We are the lesion is above the spinal cord and bilateral. Why you are going for a spinal cord lesion? So it is not only involved with the spinal cord, but also involved the brainstem.
Okay, sir.
Okay?
Okay, sir.
So then the differential diagnosis must be something other than spinal cord.
Yes, sir. It would be multifocal motor neuropathy.
See, neuropathy is a LMN. It is a neuropathy, multifocal motor neuropathy, LMN. See, bilaterally corticobulbar fibers affect. Now, what are the conditions? You will get bilateral cortico apart from ALS. Any other condition, bilateral corticobulbar fibers, multiple sclerosis you can think of?
Yes, sir. Yes, sir.
Multiple sclerosis can also you can think of. Vascular cause also you can think of. Okay?
Okay, sir.
So these are also can produce present like this. Emotional instability.
Yes, sir.
Bipyramidal sign. All these things can vascular and demyelinating lesion like MS can produce this type of symptom. Okay? So that also taken into account. So the only point this disease progress is rapid.
Yes, sir.
Okay?
Okay, sir.
Sir, Namachaya sir.
Not taken, sir.
Me.
Gayatri,
Sir, sir.
what are the main structures involved in emotion? Cortico-bulbar and Soviachi, what are the structures that could play a role in emotion in the cortex? You should know cerebellum specific function.
Hypothalamus, amygdala, limbic system involved, sir.
Amygdala, hippocampus,
Prefrontal cortex,
cingulate
hippocampus,
cingulate cortex. In this one,
sir, limbic system, hypothalamus,
hippocampus, amygdala, cingulate cortex. All this are involved in emotion. Okay.
Emotion.
So you should know the basic structures that could play a role in emotions. Okay.
Okay,
Okay.
Yes,
So you told it's a pseudobulbar palsy. Pseudobulbar, bulbar involvement.
In a pseudobulbar involvement, sir.
What are the other components? You told what are the person had dysphagia, right?
Yes, sir, dysphagia, sir.
What are the other components? In pseudobulbar, what are the other components?
George was disaggregated on examination, sir. Spastic dysarthria present, sir. In pseudobulbar palsy. Dysphagia was present. On examination.
You told dysarthria, you told what else he had?
Emotional ability.
Emotional liability was there.
Yes, sir.
Okay. So you should know the basic structures involved in either. What are the conditions where you told bipyramidal involvement? What are the conditions where you get bipyramidal involvement?
In pseudobulbar palsy, bipyramidal involvement will be seen, sir. And in motor neuron disease, multiple sclerosis, cervical myelopathy, sir. And some
cervical.
Sir,
Okay.
cervical myelopathy, sir.
Can you get in bilateral cerebrovascular accident?
Yes, sir.
Or you can have a massive infarct with the compression on the opposite side, producing bipyramidal signs. So massive infarct, midline shifter. As a person can have bipyramidal sign, bilateral plantar etc. You have to think of various possibilities. Okay, what you said was correct. Pseudobulbar MND varum sollirken. Pseudobulbar palsy agreed. Adhe mari cervical myelopathy you said it can be bilateral cerebrovascular disease. Okay.
Yes, sir.
Aprom அடுத்தது வந்து இது just now a massive infarct with midline shift compressing the opposite side that can also produce bipyramidal side. So you are the clinician who has to decide what is the real picture in the patient. Okay.
Yes, sir.
Bipyramidal side. அப்புறம் கொஞ்ச நேரம் கழிச்சு last to trace the pyramidal pathway. ஆமா சரி proceed.
General examination, the patient is conscious and cooperative. She was oriented to time, place, and person. She is a right-handed individual, poorly built and nourished. No pallid ictus, cyanosis, lumping, pedinedema, or lymphadenopathy. Length 138 cm, weight 48 kg. Height neck ratio is less than 13:1. No low posterior hair line. No evidence of neurocutaneous markers. No markers of TB or HIV or syphilis. No peripheral nerve thickening present. No hypo or hyperpigmented patches, and no spiniformity. Vitals pulse rate 88 beats per minute, regular in rhythm, normal in volume and character, felt in all peripheral vessels, no radial or radiofemoral delay, no vessel wall thickening was present. And carotid artery, there was no bruit. BP 120-70 mm mercury in the right arm in supine position, and 110-70 mm mercury in left arm in supine position. The rate was 16 breaths per minute, regular rhythm, abdominal thoracic type, and SpO2 is 98%, temperature 98.6 degree Fahrenheit. CNS examination, higher mental functions. She
One
was
thing you missed in general examination, which is very important. What are the things you missed here? You hear
twitching
of
possibility.
single breath count. Single breath count.
Single breath count.
Single breath count. Is it important or not?
Yes, sir. It is important, sir.
Mm.
Respiratory muscle weakness in muscle weakness.
Okay. So you start with once again. Now you come to the higher mental function. You can go for general examinations. Why you put go ahead previous slide. Why you have put conscious, cooperative, oriented to time, place, person, right-handed individual in general examination?
The organization.
Then
Whether
you
it
are
is
having
intact or
CNS examination, higher mental examination. Now you go for CNS examination.
okay, sir.
Why once again you are putting here conscious, cooperative, right-handed individual, oriented to time, place, person, two place. Why you are putting this? General examination is not a place for conscious, right-handed, orientation, build nourishment, anemia, jaundice, lymphadenopathy. You will put then case-specific general examination is very important. So there is a separate column for higher mental function examination. Okay.
Okay, sir. Okay, sir.
So unnecessarily you are putting in general examination.
Okay, sir.
Not only you, there is a dictum in all students are doing like this only. Okay, you go ahead.
Okay, sir. Higher mental functions, conscious and cooperative, right-handed individual. She was oriented to time, place, and person. Memory, all the three components of memory was intact. Intelligence normal. There was emotional ability present, and concentration was normal. Speech, there was past.
There is an order for higher mental function examination. Okay. First
Okay,
thing,
sir.
consciousness. Okay.
Okay,
If it
sir.
is affected, you cannot further examination. Next
Okay,
is
sir.
appearance and behavior. Without examination, you are observing the patient. Okay. Next
Okay,
is
sir.
attention vigilance. Okay. Without
Okay.
attention, you cannot go for further examination. Next is the orientation in time, place, person. Then language, then memory, intelligence. If everything is normal, then you can test intelligence. Okay. So this
Okay,
is the
sir.
order of higher mental function examination. You
Okay,
cannot
sir.
jump from here and there. First consciousness, appearance and behavior. Then attention vigilance, orientation, time, place, person, language, memory, intelligence. This is the order always you must go ahead. Okay.
Okay, sir.
If one is affected, you cannot go for further examination.
Okay, sir.
Okay.
There was emotional ability present, and speech was past in dysarthria. Coming to the cranial nerve examination, olfactory nerve, optic nerve was intact on both sides. Cranial nerves 3, 4, and 6 was normal on both right and left side. Trigeminal nerve on both sides, there was no wasting of the muscles of mastication, and sensation was normal, touch, pain, and temperature. Corneal nucleus, conjunctival nucleus was normally present on both right and left, and jaw was present. And facial nerve examination, it was normal only, sir. There was no deformity. The sensation of the facial nerve was also normal on both sides. Vestibular cochlear nerve, Rini test, ear connection better than bone connection on both right and left side. In Weber test, there was no lateralization of sound, and there was no nystagmus or swaying. And coming to the 9th and 10th nerve, symmetry of the palatal arch was normal, but the jaw jerk was disaggregated. Spinal accessory nerve was normal. There was shrugging of shoulders was normal on both sides, and turning the head sideways was also normal. Hypoglossal nerve examination, tongue fibrillations was present. But she was able to control the tongue, and she was able to press against the buccal aspect of cheek. And movement was on the tongue was also normal from
Hello. Hello.
Hello? Hello? The sound is very well.
Doctor, what happened?
side to side.
Gayatri.
Patient in the second question, while
You go
sir,
for
சொல்லுங்க sir.
previous slide, 12th nerve.
12th nerve காமி.
Sir.
அதுக்குள்ளேயே அடுத்தது வந்து 12th nerve.
12th nerve, cranial nerve examinations. What happened? Hello?
Sir, I think she got disconnected, sir.
Huh?
She's got disconnected.
Sir, she's disconnected, sir. She has to rejoin back.
இல்ல யாரோ ஹெல்ப் கேட்க வேண்டியதுதானேப்பா.
டாக்டர் பழனியப்பன் வரலீங்களா சார்?
இல்ல, I think he's feeling sick or something, sir.
Sir?
இல்ல, he's not feeling well. That's what they said, sir.
Okay.
Sir, can you hear me, sir?
Here.
Exactly.
Yes, sir. Sorry, sir, some connection problem, sir.
Okay. Yes. Fine. No. Previous slide.
Okay, sir.
Tongue examination, you have to palpate the tongue, whether it is flabby or spastic. Then tongue fibrillation, unilateral or bilateral.
It was bilateral tongue fibrillation.
Which one is important in this case? Your audio not clear. I think. Hello? Keep the mic near your mouth.
Sir.
Tongue fibrillation.
Can you hear me?
Your voice not clear, doctor. Gayatri, keep your gadget properly. We are not able to hear you properly. You can ask the help of someone, to be along with you. She will explain that.
Hello?
Help me. Somebody can help her, no? Girls were irukanga. Yeah, because when you prepare, when you want to present something, now the guidance of some other colleagues, the girls were irukanga. Amika admission day, இந்த வேற பொண்ணு கமலி யாரோ இருக்காங்க இல்ல, அவங்க வரச்சு. You're presenting from the hostel. எங்க இது நல்லா இருக்குமோ டவர் அந்த இடத்துல ஹெல்ப் பண்ணி சொல்லுங்க.
Namachoy, sir.
Sir?
What happened?
Other than sir, we have somebody to help us, sir, in the hostel.
Disconnected, huh?
Amma, sir. Other sir, the girls, girls, help sir. So the hostel is free.
Hello, sir.
Ma, ask the help of someone. If you are alone, you ask somebody to come and help you.
Okay, are you able to hear, doctor?
Yes, sir. Am I audible, sir?
Audible. Now it is clear.
Yes, sir.
So
Sorry,
whenever
sir,
you observe the tongue, you must look for fibrillation bilaterally or unilaterally. What is the importance, bilateral or unilateral?
It's bilateral, sir.
What is the importance? Suppose unilateral wasting and fibrillation, bilateral fibrillation and wasting.
Sir, unilateral, it means one side nerve involvement.
So unilateral mean mostly it is a hypoglossal nerve. Bilateral fibrillation means mostly it is a anterior console, hypoglossal nuclei. Okay?
Yes, sir.
This is one of the high positive predictive value for diagnosing ALS. If the tongue fibrillation is bilateral, this is high positive predictive value. So you have to carefully look for whether it is unilateral or bilateral. Okay? You have to palpate the tongue also.
Yes,
Whether
sir.
it is spastic or flabby.
You have to feel.
Yes, sir.
Did you feel the tongue?
Yes, I felt, sir, it was spastic tongue, sir.
Spastica.
Yes, sir.
After how will you put fibrillation here? You're contradicting your own statement.
Sir, on and off fibrillations only was present.
Huh?
So fibrillations was present on and off, sir.
So,
both
the LMN as well as EMN you are getting, la?
Yes, sir.
Both the LMN and EMN is there. Huh?
Yes, sir.
Okay.
What are the other conditions you get fibrillation? The tongue.
Sir, in bulbar palsy, in syringomania, in oneomyelitis.
What other apart from neuro? Think
sir. Thyrotoxicosis.
Hyperthyroidism. Where do you get macroglossia?
B12 deficiency, sir. B12 deficiency, macroglossia.
Vitamin B12 deficiency. There are some number of causes. Hypothyroidism, acromegaly, Down syndrome, amyloid, Beckwith syndrome. Vitamin B12 deficiency, you get hyperpigmentation of your tongue. Don't say vitamin B12. Which book gives vitamin B12? You get macroglossia. Which book gives? Tell me.
Sorry.
You should say as a postgraduate, you should give proper explanation. Okay. Undergraduate, okay. But postgraduate, you have to document whatever you say. Okay.
Yes, sir.
Proceed.
Okay, spinomotor system examination.
Spinomotor examination, attitude of the patient in the supine position, bilateral upper limbs by the side of the body, bilateral hip extended and abducted, bilateral knee joint extended, plantar flexion at the ankle joint. There was no significant difference between both limbs, but there was a gross wasting present in the upper limb and the lower limb, and wasting present in the bilateral small muscles with the thenar muscles more involved than the hypothenar muscles.
What other muscle wasted? You said the thenar muscle. Then
hypothenar muscle.
Then dorsal introsiae, palmar introsiae wasted or not?
Wasting present, sir. Wasted, sir. Wasting present in the palmar dorsal interossei, sir.
Okay. Which dorsal interossei more affected? Okay, your audio not good. Okay, go ahead. Hello.
First,
Hello.
all four limbs were hypertonic.
Voice is not clear.
Hello, sir. Hello, sir.
Yes, yes.
Clear, sir.
Audio not good, doctor.
By 5. And the elbow flexion and extension was 3 by 5. Palmar flexion. Hello, sir. Flexion and extension was 3 by 5. Palmar flexion. There is the palmar and dorsal flexion 3 by 5 on one side.
Charge your whatever you have. Say, what is a laptop or tablet? The power is less, and your voice is not very clear. You ask for help of someone.
Hello, sir. Now is it clear, sir?
Clear. Okay.
Coming to the power, in the shoulder it was flexion, extension, adduction was flexion, extension 3 by 5.
So, which you are presenting from cell phone or laptop, doctor?
Elbow flexion extension is reduced.
Hello, doctor. Any of your friend there nearby you?
Whether you're in the hostel or you're in the department library.
Sir, Namachwai sir.
Sir? Sir?
What happened, sir?
Sir, we already spoke to her. She is in the department library, sir. Department library net connection off பண்ணிருப்பாங்க sir. அந்த புது பில்டிங்ல கனெக்ஷன் கொஞ்சம் ப்ராப்ளம் சார். அட்லீஸ்ட் ஹாஸ்டல்ல இருந்தாவது கொஞ்சம் யாராவது ஹெல்ப் பண்ணுவாங்க சார். She is there in the department. அவங்க அந்த வைஃபை இது ஆஃப் பண்ணிட்டாங்க என்னன்னு தெரியல சார். ஏப்பா அங்க போச்சு வேற எங்கேயாவது இது கனெக்ஷன் போனே வராது. போன் பேசினாலே வராது. அந்த உட்கார்ந்து இருந்தா என்ன அர்த்தம்? இல்லாட்டி வைஃபை ஆஃப் பண்ணாதீங்க அந்த மாதிரி சொல்லியிருக்கணும். You have to prepare in the morning itself.
Any of her friends are there, are helping?
Sir, 2 of them have gone to help her also. PG sports only, sir. ஃப்ரீ தானே இன்னைக்கு. அப்ப வந்து அங்க இருந்த மேல பசங்களை கிளாஸ் எடுத்துட்டு இருந்தேன் 6th floorல. வந்து எந்த மாதிரி ஒரு இடத்துல கரெக்டா பண்ணலாங்க. ஃப்ரெண்ட்ஸ் கிட்ட கூட கேட்க மாட்டீங்களா? இந்த டிஸ்கஷனே அந்த ஃப்ளோ போயிடும். அப்புறம் நெக்ஸ்ட் டைம் அது மாதிரி பண்ணக்கூடாது. We want to present with as a help person who knows either tablet or computer or whatever it is. எங்க நெட் கனெக்ஷன் நல்லா இருக்கும் அங்க உட்காந்துக்கோங்க. காலேஜ் லைப்ரரி நல்லா இருக்கும் இல்ல, ஆனா மூடிட்டு வாங்கணும். இதெல்லாம் வருதா ஷேரிங்? ஒருத்தர் பேசிக்க கூட மாட்டீங்க புறப்படுகிறது தானே. There's a definite divide between all your people.
Hello sir, I connected. Sir.
Next time don't do it like this. Purida.
Yes sir, sorry
sir.
Ask
the help of someone who knows computer well. You can tackle all the problems that arises. And the flow point on there.
Sorry sir.
Arya. Proceed.
Yes sir. Coming to the bulk and coming to the bulk, there was no significant difference between both sides, but there was gross muscle wasting present. Tone, there was hypertonia on all 4 limbs. Power was reduced. It was 3/5, and in the elbow flexion extension also 3/5 on both sides. Thumb flexion extension was 3/5 on both sides. Finger flexion extension was 2/5 on right and left side. Hand grip was reduced. Trunk muscles, hip flexion was 3/5 on both sides. Extension 4/5. Adduction and abduction was 3/5 on both sides. Knee flexion and extension was 4/5. And fasciculations was present in the right eye. Ankle dorsiflexion and plantar flexion was 3/5 on both sides. Toes flexion extension was 3/5. Reflexes, superficial reflexes was normally connected, and the plantar was extensor on both sides. Deep tendon reflexes, it was disaggregated. Biceps
Don't
was
hurry up. Just wait. Don't be very fast. So which,
okay, sir.
what type of hypertonia get in the upper limb and lower limb in pyramidal tract disease? Which group of muscle will go in for hypertonia in the upper limb and in the lower limb? Basics on the tell me. Basic தெரியாம அப்புறம் எப்படி பண்ணி என்ன யூஸ்?
Anti-gravity muscles in the upper limb muscle.
Anti-gravity, flexor, extensor.
Sir, flexors in the upper limb and extensors in the lower
Flexor
limb.
அது சொல்ல இத்தனை நேரமா. Flexor hypertonia in the upper limb and extensor hypertonia in the
lower limb, sir.
lower limb. Weakness எங்க common? Upper limb ல எந்த muscle will go for weakness and lower limb ல எது will go for weakness? Which groups of muscle?
So, lower limb ல வந்துட்டு quadriceps muscles.
The individual muscle கேட்கல flexor extensor group எது weak ஆகும் upper limb ல? Upper limb, lower limb.
Upper limb ல flexors weak ஆயிடும், sir.
It is opposite. Weakness for the extensor weakness in the upper limb and flexor weakness in the lower limb.
Okay, sir.
Okay. Which groups of muscles are earlier to be lost in the pyramidal tract disease? Which one's a bipyramidal disease? Leah, which groups of muscle are going to be involved earlier in the pyramidal tract disease?
Sir, upper limb la extensors will be affected early, sir. Lower limb la வந்து flexors will be affected.
A group of muscles கேட்கல. Which movements will be affected earlier in the pyramidal tract disease?
Wrist extension, finger extension will be lost, sir. Extension will be lost in the upper limb, sir. And
அதே சொல்லிட்டு இருக்க which movement ன்னு கேட்டேன். Find distally learned skilled movement or lost earlier. புரியுதா? And they are the last to recover. The hemiplegia case ஒழுங்கா பார்த்திருந்தீனா இதெல்லாம் நீ கரெக்டா சொல்லுவ. This was taught to us by our teacher. யாரு? காமாட்சி செம்பவுன்னு ஒரு மேடம் in 1988. Still we remember. நீங்க சும்மா என்ன படிச்சிட்டு basic do not know. So find distally learned skill movement are lost earlier and they are late to recover. So the basics தெரிஞ்சிட்டு அப்புறம் you keep presenting. Just like that, don't be very fast. So flexor hypertonia, extensor, flexor hypertonia in the upper limb, extensor hypertonia in the lower limb. புரியுதா? அப்புறம் weakness வந்து is opposite, extensor weakness and flexor weakness. In the pyramidal tract disease, find distally learned skill movement are lost earlier and they are the one to recover later. So இதெல்லாம் you have to observe. ஒரு கேஸ் பண்ணும்போது to concentrate on the basics. Superficial ஏதாவது பண்ணக்கூடாது. புரியுதா? Present now.
Reflexes, superficial reflexes was present on both sides and plantar was extensor. Deep tendon reflexes, biceps, supinated triceps, pectoralis was 3+ on both sides. Trapezius, it was 2+ on both sides. Finger flexion, 2+ on the both sides. Knee jerk and ankle jerk was 3+. Sensory system examination was intact in the upper limb and in the lower limb also it was intact.
What type of reflex or deep tendon reflexes? What type of reflexes? And what type of reflexes, superficial reflexes are?
So deep tendon reflexes are flexor reflex. DTR or stretch reflex, sir.
What did you say?
Monosynaptic stretch reflex, sir.
Stretch reflex.
Oh, yes, sir.
Biceps tricep என்ன மாதிரி reflex இது? What type of reflex they are?
They're monosynaptic reflexes.
Monosynaptic. அப்புறம் superficial reflex.
Superficial reflexes are polysynaptic reflexes, sir. It is polysynaptic reflexes.
So what nerve ending innervate the muscle spindle? What efference? The basic is your intrafusal fiber, extrafusal fiber, which innervates a muscle spindle, which innervates a intrafusal fiber. What innervates the muscle spindle? என்னம்மா gamma efference புரியுதா? பேசிக் physiology தெரியணும், சும்மா படிச்சுட்டு எதையா சொல்லக்கூடாது. அப்பதான் you know your the disease well and you can give appropriate treatment. Proceed.
Sensory system, spinal impression intact, vibrations, pressure sense intact, joint and motion sense intact, and on the both sides, in the upper limb and in the lower limb, sensory system was intact. Cerebellar function would not be done because of the muscle weakness. And there was no nystagmus, no intentional tremors, no intubation, and no abnormal sweating or palpitations.
Can
no
the cerebellum be involved in motor neuron disease?
Yes, sir, can be involved, sir.
Oh, there was no cerebellar side. You are doubly sure. Huh?
Sir, cerebellum can be involved in motor neuron disease, sir.
Yeah, but here there was no. What are the functions of cerebellum? Motor functions of the cerebellum.
Sir, to maintain the posture.
Necessary for maintenance of posture and tone. Secondly, necessary for coordination of movement. Third,
yes, sir.
necessary for performing alternate movements. Necessary for dampening of movements. That is, you overshoot the target. So these are all the functions of cerebellum.
Sir, பார்த்தேன் சார். அந்த பேஷண்ட் மசில் வீக்னஸ் இருந்ததுனால அந்த இதெல்லாம் பண்ண முடியல சார். அவங்களால எழுந்தி உட்கார முடியல. இந்த வெயிட் போர்ஷன் இதெல்லாம் பார்க்க முடியல சார்.
There is no cerebellum involved. Sure.
Yes,
okay.
Sir.
Extrapyramidal, adakano? Can extrapyramidal system be involved?
No, sir. Extrapyramidal system involved ஆகல சார். ஆனா it can be involved in ALS, sir.
அது பார்க்கல, நீ மென்ஷன் பண்ணலையே, ஏன் பண்ணல?
இன்வால்வ் பண்ணிருக்கேன் சார். அடுத்த ஸ்லைட்ல போட்டிருக்கேன் சார்.
போட்டியா?
போட்டிருக்கேன் சார்.
சார் சார்
சொல்லுங்க சார்.
சார் நீங்க கேளுங்க சார். What are the other systems that can be involved?
Okay, let her complete.
Okay, sir. Okay, sir.
So you summarize, doctor.
Sir, it is a chronic progressive asymmetrical spastic quadriparesis with 9 and 10 renal nerve involvement, with the wasting and fasciculations, with the normal sensory, normal higher functions, normal bowel bladder functions, and spinal cranium, sir. So the structures involved are corticospinal tract, corticobulbar tract, and anterior horn cells. The pathological diagnosis would be ALS, degenerative ALS, sir.
இனி இதுல மென்ஷன் பண்றது a chronic progressive asymmetrical spastic quadriparesis. அப்படிதானே? Involving both the upper limb and the lower limb.
Yes, sir.
Okay. அப்புறம் distal proximal more அதெல்லாம் நீ மென்ஷன் பண்ணவே இல்ல. அப்புறம் symmetrical asymmetrical அதெல்லாம் ஊருக்கு asymmetrical you said.
Yes, sir.
Distal weakness more, proximal weakness more. அது மென்ஷன் பண்ணணும்.
Okay, sir.
Distal
Distal is
weakness
more.
போறா
Oh, yes, sir.
சரி அப்புறம் spastic அது போட்டுருக்க அப்புறம் you have to mention in order first எடுத்த உடனே higher function no higher function disturbance okay அப்புறம்
Okay, sir.
sensory system அப்புறம் no cerebellar no bowel bladder it has to be in that order புரியுதா
Okay, sir.
மாத்தி போடக்கூடாது எந்த ஆர்டர்ல you're presenting that orderly you have to summarize your diagnosis அப்பதான் you can come for a clear cut diagnosis புரியுதா okay
Okay, sir.
Okay, doctor, during spinomotor examination, certain things you missed it. Did you mention about fasciculation? Site
Oh,
of
yes, sir.
fasciculation in the body?
Fasciculation is present in right eye, sir.
Then hands, any fasciculatory tremor?
No, sir, it was not in the hands, sir.
Any finger drop?
No, sir. No, sir.
You are having the picture of the patient?
Picture on the patient. No, sir, I don't have the picture, sir.
Okay. Then you said wasting of thenar muscle.
Oh,
More
yes, sir.
than compared to hypothenar.
Yes, sir.
There is wasting of dorsal introsei. What is it? What is the sign called?
Split hand sign, sir.
Split hand sign. What is split hand sign?
Sir, abductor pollicis brevis will be lost.
What is the importance? What information you will get from split hand sign? See, split hand sign, what are the features? One, wasting of thenar muscle.
Yes, sir.
First dorsal introsei, preservation of hypothenar. Okay.
Oh, yes, sir.
So, thenar supplied by which peripheral nerve? Thenar muscle.
Median nerve, sir.
Median nerve. Hypothenar.
Ulnar nerves.
Hypothenar and dorsal introsei supplied by ulnar nerve. But here, there is wasting of dorsal introsei and thenar muscle.
Yes,
so,
sir.
what it indicates? It is not the nerve. It is not nerve. Okay.
Yes. Oh, yes, sir.
So, if it is a nerve, na, hypothenar and introsei will be affected. Or thenar only affected. So, it is not median nerve, it is not ulnar nerve, it is involvement of anterior horn cell, C8T1 segment. Okay.
Okay, sir.
One. What is the importance of this sign in ALS?
Split hand sign is early and specific sign of ALS, sir.
What is the reason? So, we are using the thumb and index finger more frequently. Human,
Yes, sir.
So, these motor neurons are early degenerated in ALS. Okay? Precise hand. Thumb and index finger are called precise hand. We are more frequently using all these things. So, there will be early degeneration of this from the motor cortex. Okay?
Okay, sir.
Then another importance is in this case, what is a bilateral fibrillation of the tongue? Then second point. Then you said 9th, 10th cranial nerve involvement. Is it cranial nerve or nuclei or corticobulbar fibers? It is not nerve. Okay?
Okay,
not
sir.
glossopharyngeal nerve, not vagus nerve.
Okay, sir. Corticobulbar fibers.
Corticobulbar fibers are the nucleus of the 10th nerve. Okay?
Okay, sir.
That they are more affected. They're not nerve. You should not mention nerve. Okay?
Okay, sir.
Then there is presence of LMN sign and UMN sign. How many regions the patient is having? There is lumbar region. Okay?
Okay, sir.
Then dorsal, cervical, bulbar.
Oh, yes, sir.
4 region. Both LMN as well as UMN affected. That means more than 3 region affected here. Okay.
Oh, yes, sir.
What is the point strongly suggestive of anterior horn cell? Wasting, fasciculation, okay,
Oh, yes, sir.
with the preserved reflex or brisk reflex. It is a sign of anterior horn cell with the pyramidal tract involvement. Okay.
Oh, yes, sir.
So here there is a degeneration of the anterior horn cell, degeneration of the corticospinal tract and corticobulbar tract, more than 3 region bilaterally affected and progressive course, no sensory involvement. Okay.
Oh, yes, sir.
So the jaw jerk is brisk in this case. What is the importance of jaw jerk? Suppose the jaw jerk is absent.
Oh, yes, sir.
Patient is having no bulbar weakness. Bipyramidal tracts in the both the upper limb and lower limb. Weakness, wasting. What is the indicate? What is the jaw jerk importance? When a patient is having quadriparesis with intact jaw jerk or normal jaw jerk or absent jaw jerk, okay?
Oh, yes, sir.
It localizes the lesion in the spinal cord.
Oh,
When
yes,
there
sir.
is a bipyramidal sign, okay, with the
Oh,
brisk jaw jerk, that take the lesion above the midpoints, above the
Midpoints.
midpoint, midpoints, not point, okay?
Oh, yes.
So that indicate not spinal cord, it is a pseudobulbar
Oh, yes, sir.
picture, okay? Corticobulbar fibers involvement. So pure motor, now it is has almost all criteria fit for ALS, okay?
Yes, sir.
LMN side, EMN side, more than 3 region, bilateral and progressive course. So you think of ALS as the first possibilities, okay?
Oh, yes, sir. Yes, sir.
So only thing that the age of onset little earlier compared to normal, a typical ALS.
Yes, sir.
What is juvenile ALS?
Sir,
Less
ALS
than
according to the
25 years of
definition,
age. What we
yes, sir.
call as juvenile ALS, okay? So what is the atypical features of ALS? What is the spectrum of presentation of ALS? Here we got both the LMN, UMN, all these things. One extreme predominantly LMN, another extreme is a predominantly
UMNs.
EMN. Okay.
Yes, sir.
So if it is predominantly UMN, what we call it as?
EMNs, primary stenosis.
Lateral sclerosis. So to say primary lateral sclerosis, what are the essential points you need? The patient must present with the EMN sign alone minimum 4 years. Okay?
Yes, sir.
Minimum 4 years. Only EMN sign, minimum 4 years, and exclude all other causes. Before labeling as primary lateral sclerosis, it is a rare diagnosis. Okay?
Oh, yes, sir.
Then only LMN, what we call it as?
Spinomuscular atrophy.
Not progressive muscular atrophy, not spinal muscular atrophy.
Progressive muscular atrophy.
So progressive muscular atrophy. Okay. In between this, you can get bulbar onset ALS. Okay.
Oh, yes, sir.
A typical ALS, all this thing. Okay.
Oh, yes, sir.
So, which one is better prognosis? Which one is bad?
Yeah, progressive muscular atrophy, better prognosis, sir. Bulbar onset,
progressive muscular atrophy and primary lateral sclerosis are very slowly progressive. Okay.
Okay, sir.
Very slowly progressive, little slowly progressive. Whereas bulbar onset, early death occur. Why?
Because the respiratory muscles will be involved
Respiratory aspiration, pneumonia, and other thing. Bulbar
yes,
weakness, dysphagia, because they will die little early. Okay.
yes, sir.
Survival minimum less than 2 years. Okay.
Okay, sir.
Next. Any other atypical present variant of ALS? What is respiratory onset ALS? 3% of the patient present with diaphragmatic involvement. They also die early because of the respiratory distress. Okay.
Okay, sir.
So in this case, you didn't mention about claw hand deformity, all this thing. When a person having small muscle wasting, definitely they must be having clawing deformity, all this thing.
Oh, yes.
So this is very, very important. So then the ALS, now it is a neurodegenerative any spectrum. So cognitive function assessment also very, very important in ALS patient. Particularly frontal lobe dysfunction more common in ALS patient. Okay.
Okay, sir.
Then what are the positive predictive value for ALS? Highly positive. One is you said split hand sign.
Split hand signs.
Another second is bilateral fibrillation of the tongue. Third is pyramidal signs with the pseudobulbar features. Then dropped head, that is due to extensor weakness. So the myasthenia also sometimes closely mimic like this.
Okay,
This
sir.
is one of the differential diagnosis you might come across, myasthenia. Okay.
Okay, sir.
So these are the highly positive predictive value. These signs, split hand sign, bilateral fibrillation of the tongue, pseudobulbar effect, and cognitive frontotemporal with pyramidal signs. These are high positive predictive value for ALS.
Okay, sir.
Then why ALS, the ocular muscles not affected, and what are the things not affected in ALS?
Extraocular muscles will not be involved. Cognition, bowel and bladder will not be involved. Sensation will not be involved.
Why extraocular and nucleus on of not involved? What is nucleus on of? It is an anterior hand cell.
Okay.
S3, S4, S5. Okay.
Okay, sir.
It is an anterior hand cell. All other anterior hand cell affected, but the nucleus on of not affected.
Okay, sir.
Bulbar muscle affected, ocular muscles not affected.
Yes, sir.
What is the reason?
Because the radial nerve nuclei of third, fourth, and sixth nerve are selectively resistant to regeneration, sir.
What?
They are resistant to regeneration, sir. They have
which book it is mentioned? So the spinal neurons, anterior hand cell, how they are connected with the muscle? Sir already asked, Dr. Namchivayam asked, monosynaptic reflex.
yes, sir.
So motor neuron, ALS, there is a degeneration of the neurons which has got monosynaptic connection. The nucleus and the ocular muscle doesn't have monosynaptic connection. Monosynaptic, if you tap a tendon, afferent go through the dorsal root, activate the anterior hand cell, then efferent comes through the anterior root and muscle contraction. That is monosynaptic reflex. So the neurons which it doesn't have monosynaptic connection, that is ocular muscle and nucleus on doesn't have monosynaptic connections. So these neurons are spared in ALS. Okay.
Okay, sir.
Today you go and see that explanation why ocular muscles and nucleus on not involved in ALS.
Okay, sir.
Then the cognitive was important. Then any other system affected by ALS? So it may involve the extrapyramidal system, what we call it as ALS Parkinsonism. What complex? Guyam complex. Huh?
Guyam complex.
Oh, okay. ALS FTD frontotemporal dementia. Then ALS with deafness. Okay.
Okay, sir.
Sensory symptoms are described, but sensory deficit not yet reported. Only thing, there is a one type of ALS, whereas facial onset trigeminal neuropathy. It is a type of ALS. There is bilateral trigeminal sensory also affected.
Yes, sir. Midwest motor neuron disease.
There it is associated with deafness. Nowadays, the term Madras motor neuron not used.
Okay, sir.
Previously, it is occur in age, young age with the deafness. All these things are described, but all are now contest journal ALS. Okay.
Okay, sir.
Then any other doubt you are having in the ALS?
No, sir.
Namaskar, sir.
Listening, sir. Sir,
What investigation you will do for this case, doctor?
Electrophysiological studies, sir.
Very good. What will you
share your slide for investigation.
So what will indicate? To confirm anterior console involvement, we must do nerve conduction study along with the needle EMG. Okay.
Okay, sir.
Then suppose the patient is having only LMN sign, progressive course. What is the investigation to find out occult UMN finding in a suspected ALS patient? Transcranial magnetic stimulation. If you demonstrate hyperexcitability of motor cortex with the transcranial magnetic stimulation, it is another, you can take it as a UMN sign. When the UMN signs are subtle, only LMN sign, still you are suspecting a MND ALS. You have to do transcranial magnetic stimulation and demonstrate motor cortex hyperexcitability.
Okay, sir.
So, what are the conditions which mimic ALS? See, phenotypic variation, that is different. What are the conditions which mimic ALS?
Myasthenia gravis, syringomyelia.
Okay, very good. Now you can say cervical myelopathy, multifocal motor neuropathy. They can also mimic ALS sometimes. Okay.
Any endocrine disorder?
Hypothyroidism, sir.
Thyrotoxicosis.
Thyrotoxic.
Are you heard of thyrotoxicosis? What skin finding you will get a thyrotoxicosis? What is pretibial myxedema in thyrotoxicosis or hypothyroidism? Pretibial myxedema.
Gayatri, what happened to you? Shilpi is off the board. He's not answering.
Pretibial myxedema occur what condition, doctor? Hypo or hyper?
Disconnected. Then why she's not answering? Shilpi disconnected.
Okay, she is tired, I think.
Next time, don't make such mistake. Another friends.
Sir, or shall we conclude or anything?
Shall we conclude, sir? It's already 10, sir.
Okay, sir. You can conclude, sir.
Okay, sir. Okay, sir. We'll meet, sir. Nice. It was nice listening to you, sir. Thank you, sir. Wait a minute.
No, sir. Sorry, sir. Some connection problems, sir. Endocrine disorders வந்து hypothyroidism, thyroid disorders can mimic
Pre-tibial mixed edema in hyperthyroidism or hypothyroidism? Pre-tibial mixed
hypothyroidism,
edema.
sir.
Huh?
சொல்லுமா, what
Hypothyroid.
happened?
Hypo, sir.
No, it is
Hypothyroidism.
hyperthyroidism. That's why I
Hyperthyroidism.
asked the question. Okay. So thyrotoxicosis, one of the, you will get wasting, brisk or hyperexcitable reflexes, mimic ALS like finding. Okay. That is
Then-
also
Yes, sir.
one of the differential diagnosis.
Gayatri,
Sir.
Gayatri,
Sir.
can
Yes, sir.
organophosphorus poisoning mimic MND?
Yes, sir.
How?
Sir, shall we conclude, sir?
Yes, sir.
Yes, sir.
Okay,
OPC poisoning will cause delayed neuropathy, sir. So it can mimic ALS.
What?
Yes, sir. I asked her whether OPC poison can mimic MND.
You can conclude, sir.
Yes, sir. Yes, sir. Thank you, sir. Okay, sir.
Dr. Gayatri, you presented well. Only thing is some problem with the network, I think, or your phone.
Okay.
Okay.
Sorry, sir.